Good evening, everyone. You're warmly welcome to today's function. Thank you for being on time. We would want to crave your indulgence and your permission to maybe wait a few more minutes, maybe 2 or 3 minutes, if we can get maybe 2 or 3 more people, and then we can begin today's function. Good evening once again. Thank you very much for your patience. I think we can begin now. We are very thrilled to have all of you here for this very special occasion. Thank you for joining us today for this very momentous occasion. We are here even though virtually, but we are here to still celebrate a very significant step towards the fight against blood cancer. And so we are beginning with the virtual launch of the Blood Cancer Foundation. To speak to us today, to begin everything and tell us as to why we are here and everything concerned with the Blood Cancer Foundation, as a specialist hematologist at the Cape Coast Teaching Hospital. His name is Dr. Emmanuel Kisidu Antiri. Doc, if you can hear me, the floor is yours.
Yeah, thank you very much for the brief introduction. I hope everyone can hear me. Hello, I hope everyone can hear me.
Yes, we can.
All right. Okay, so again, thank you very much for joining us today. And today we are here virtually because we want to launch the Blood Cancer Foundation. And we've seen that it's been necessary because of the increasing number of cases and also the difficulties that these patients face when they have to be diagnosed and treated. And it's past 6 p.m., so I'll just quickly share my slides so that we can have enough time for questions and discussions and as more people also join. Okay, so at the end of the meeting today, we should just take a brief look at an introduction to blood cancer. We will look at the statistics for 2024 at the Cape Coast Teaching Hospital, and then the turning point for the Blood Cancer Foundation, the situation in Ghana, our vision and mission, and then we take some questions and have a discussion. So blood cancer in general, before you have to understand what blood cancer is, you have to know what cancer is. So a cancer is a disease that is caused by an uncontrolled division of abnormal cells in any part of the body. So if, let's say, someone has a breast cancer, that means that the normal cells in the breast has become abnormal. So the abnormal cells in the breast, they just multiply in an uncontrolled manner, and they occupy the limited space within the breast. So that's why in some breast cancers, you realize that the breast has become enlarged. It's because the cancer cells are multiplying and they've occupied a fixed space. So blood cancer, based on the foundation that I've laid, blood cancer is basically a cancer that occurs in blood cells. So it begins in blood-forming tissues like the bone marrow or cells of the immune system, or I mean tissues that contain various cells that form part of the immune system, and they include the lymph nodes, the spleen, which is found at the side, the thymus, which is found in the chest. And I decided to bring the chicken bones here because I wanted something that you could relate to. And the closest I could get was a chicken bone, which a lot of us have chewed before. So you realize that this side of the chicken bone, I mean the ends of the chicken bone has where we have the, like that's where you have the bone marrow. So here and here. And when you look, when you bite to the side, you realize that there's this red to dark brownish matter in that area, and that is where you have your bone marrow. So that is what we as adults, or we as human beings, I mean children and adults, this is what you find in our bones, and this is what makes the blood cells, okay? And if you have a cancer, it begins from these tissue, that's the bone marrow, or the other tissue that I mentioned, the spleen, the thymus, the lymph nodes. So it begins here, and subsequently, once they multiply within the bone marrow, they move from the bone marrow and enter other tissues like the liver, the central nervous system, by moving through the blood. The bone marrow makes normal cells, and to make normal cells, you need a cell called the stem cell. So the stem cell basically is like an ancestor or the parent cell, and that is where all the cells that are within the blood, that is where they come from. So they start from the stem cell within the bone marrow, and they will make these three cells, three main cells, which is the red cells, the white cells, and the platelets. The red cells carry oxygen throughout the blood. The white cells are part of the immune system and they help fight infections. And then we have the platelets that control bleeding. So I decided to show you these two pictures so that you know how your blood looks like and how your bone marrow looks like. So there are two tests that we typically do for these patients. I mean, there are more, but there are two tests. Initial test, which is the blood film comment and the bone marrow. So the blood film comment shows our cells. And to do a blood film comment, usually you realize that when you come to the hospital, we take blood from your vein. So when we take blood from your vein and we put it on a slide and look under the microscope, this is what we see. And we see red cells. So the red cells are these round circles that you see. They are the most abundant cells that you find in the blood that we take from your vein. So these red cells that you see are the red blood cells. And then the next abundant cell is the platelets. You can see some purple dots here. So those are the platelets, and that is what control the bleeding. So if, let's say, you have a cut somewhere and you are bleeding, this is what actually stops you from bleeding. I mean, you bleed a little and then it stops it. And then we also have the white cells, which is the last most abundant cells within that is found within the blood that is taken from your vein. So these are the white cells. These two cells you see here, they are the white cells. And if we go into the bone marrow, we want to see where these cells that are found in the blood that we took from your vein, where exactly are they coming from? They're coming from the bone marrow. So in the bone marrow, we see the parent cells and the cells that are subsequently maturing to become these matured cells that are found in the blood that we took. So for the red cells, as I pointed here, for instance, they start off from these nucleated cells that you see here. Okay, so as you can compare, you realize that the cells that have a nucleus in the film are just two here, 1, 2. But if you look at the bone marrow, the cells that have nucleus are a lot. This one is the nucleus. I mean, if you take this cell, this purple thing here is the nucleus, and this little area here is the cytoplasm. And you find nucleated cells abundant in the bone marrow. So for the red cells that you see in the film here, they start off from these cells, like these cells I'm pointing to, and then they'll mature and then they'll move into the blood. For the white cells, they start off like this, then they mature into something like this, and then they'll come here, and then they'll become this, and then they'll move into the film here. And then for the platelets, this large cell that you see here, it has a cytoplasm, and this is the cytoplasm, and then this is the nucleus, and it contains the platelets in its cytoplasm. So what happens is that the cytoplasm just breaks, and once it breaks, it releases, it sprinkles out these platelets into these tiny dots, which you find in the blood. For someone who has a blood cancer, it starts from the bone marrow. So that is why every person we suspect to have a blood cancer, we want to go into the bone marrow. And if you can compare this bone marrow here to the one that we have here, you realize that I showed you different cells maturing into different cells. But if you come here, you realize that all the cells are almost looking the same. For example, if you look at this cell, it looks like it has an eye here. It looks like this one, it looks like this one, it looks like this one. So it's just one cancer cell that has decided to multiply. And once they multiply, they become a lot and occupy the bone marrow. And does not create enough space for you to have your normal red cells, your normal parent red cells, your normal parent platelets, and your normal parent platelets to also be available to mature into the cells that we found in the vein. Okay, so because of that, it is just one type of cell that has occupied your bone marrow, and these are cancer cells. And blood flows through the marrow, in and out of the marrow. So the blood that flows out of the marrow will carry these cells into the vein. I mean, the vein that we took the blood from. So if you take a sample of your blood from your vein at the back of your hand or around the forearm, we will get cells like these, which are cancerous cells, and this shouldn't be found there. So this is a blood film of someone with a cancer or with a cancer, specifically leukemia. And then this one is a bone marrow of someone showing the leukemia cells. So with the presentation of patients who have leukemia, or I mean patients who have blood cancer in general, not specifically leukemia, but blood cancer in general, they have symptoms of anemia. So they'll come in having headache, they feel tired, something little, they feel tired, their heart is beating fast, they feel dizzy. And then for symptoms of low platelets, because the cancer cells have occupied the space, you don't have platelets, and you have an increased risk of bleeding. So you can be bleeding from your nostrils, you can be bleeding from your mouth, from your ear, from your where you pass to in your urine, you can have blood coming from all these areas. And then infections also, you are bound to have recurrent infections, pneumonia, urine infections. And because the cells move through the blood to other places, organs in the abdomen like the spleen, liver, and other organs elsewhere can become enlarged. And then also you lose weight, you have fever, and you lose appetite also, and you have bone pain. And of course, if the bone pain basically is because the blood cells, the abnormal blood cells, which is the cancer cells, are multiplying in a fixed space. So if they are multiplying in a fixed space, you will start having pain coming out of pain emanating from the bone because there's limited space, but you have multiplication of abnormal cells within the bone marrow. Let's say if you have a car and it should be 5 occupants, and now 20 people decide to fill the car. That means that there's not enough space, and if the car could talk, the car will let you know that it is uncomfortable because of the number of people that are in the car. So that is how you feel the pain. And there are enlarged lymph nodes also. You can have lymph nodes enlarging around your neck, under your chin, behind your ear, in front of your ear, around your neck, and all that. And the most important thing, these are the presentation, they are variable. But again, we should also note that these symptoms I've talked about could be presentation of other diseases. For example, if you're a young lady at the age of 30 and you've been having heavy menses for a period of time and you are having tiredness or heart beating fast because you have anemia or because you've been bleeding heavily, it does not mean you have a cancer. Or if you have heavy menses because of low platelets, it doesn't mean you have a cancer, okay? And even with some of these symptoms of anemia, it could be that you are losing a lot of blood, or you probably are not eating too well, so you're iron deficient. And sometimes you can have bone pain in patients who have sickle cell or other reasons. So these symptoms are not just for patients who have blood cancer. For the causes, it occurs when you have changes in the genetic information of an individual. So the DNA or the genes that are necessary for coding certain parts of the body. So for example, if you have a gene, okay, so genes are what makes us who we are. It makes us, if a gene will let you express yourself in a certain way or will be the reason why you have your ears in a certain structure or your eye looking this way. The genes are the ones that code for these things. And what happens is that you can have an issue with the gene. So I'll give you a good example before I try explaining what starts. It's if you want to make a cake and you have ingredients to make the cake, and let's say your baking soda or your margarine or your butter is expired. If you use that material to make the cake, it will turn out bad because there was an expired ingredient in it. So that is what happens also with cancer. If the gene becomes abnormal because of certain reasons, let's say it has gone wrong because there has been a change somewhere, it's going to code for an abnormal white cell. And that abnormal white cell will be the start of making a lot of abnormal white cells, which are not dying and are making more of themselves. And the causes are generally seen in 3 ways. Firstly, and more commonly, we usually don't know where it started from. It's called idiopathic. And then for the second reason, we've seen some genetic predispositions or inherited familial predispositions where you can inherit certain genes from your parents. It doesn't mean you are going to get it, but there will be an additional factor that may starts the disease. And then finally, we have environmental factors. So if you work in an area where you are constantly being exposed to radiation, you have a high tendency of developing a blood cancer. If you develop certain infections like HIV, hepatitis C, you are constantly being exposed to chemicals like pesticides, paints, which have a lot of benzene in them, you can have a blood cancer. If you, let's say you have a breast cancer, you get chemotherapy for certain reasons, and then later on develop a blood cancer, this is likely and it's possible. or you have genetic conditions like a Down syndrome baby, they are at increased risk of developing some types of blood cancer. And then race, some blood cancers are seen more commonly in whites, some are seen more commonly in blacks. And then with smoking, the tobacco contains benzene. So being constantly exposed to benzene has been also associated with it. For the investigations, we simply do a full blood count first. And don't forget that I told you that the three blood cells that are more commonly investigated for are the red cells, the white cells, and the platelets. So when we do our full blood counts, we want to check the levels of the red cells if you have anemia or not. We want to check the white cells if they are low. Maybe that is why it's predisposing you to infections. And then we check platelets also. If they are low, probably the reason why you are having bleeding. And when we see any abnormality with the full blood count, we move on to do the blood film comments, which I showed you a slide on, because we want to really see if the abnormality can be explained by the blood film comment. Sometimes some people have a high white cell and will be thinking of a leukemia, but you just do the film and then you notice that it is an infection, okay? And with that, all you have to do is that you just have to screen for an infection and then treat the patient. You don't have to go further. But if we think the blood film is abnormal, then we move further to do a test called the bone marrow aspiration, where we insert a needle into the bone here. So this adult here we are performing a bone marrow aspiration on this adult, where we insert a needle into the bone at the back here. And then we take samples. So it goes through the bone into the bone marrow. Then we take some blood out of it. And once we take a blood out of it, we take it to the lab and then spread it so that you can see these cells here. And sometimes, generally, we should also do additional tests, like certain tests called immunophenotyping and molecular genetics, so that we can better classify your cancer and also treat you properly. With the prognosis, blood cancers in general, you can have ones that are good, or ones that the prognosis are good and ones that the prognosis are poor. And it depends on which type of blood cancer, the classification, how early the diagnosis is made, and whether there are available treatment options and even supportive therapy. So this little cartoon here shows that this white cell, which should rather be defending our blood cells, has rather decided to attack our blood cells. So you can see that this blood cell is dead because of the crosses here with the tongue out. It's so unhappy because this white cell has turned into a cancer and is trying to take it off so that this particular white cell can multiply and fill the space of these our blood cells. With the treatment, the main aim of treatment is to achieve a cure. And to achieve a cure, you have to do something called a stem cell transplant. And the stem cell transplant comes with its own complication. And even after the transplant, you can also have a relapse of the disease. The disease can come back after some years. And most of the times when we have a patient, we stratify them into whether they will get a stem cell transplant. So if you are not a candidate to get a stem cell transplant, then you are a candidate to get other treatments, which includes chemotherapy, radiation, immunotherapy, and targeted therapy. And with the chemotherapy that we do, we aim to achieve something called a remission. And remission basically means that we are trying to let your symptoms and signs disappear without cure. But to some extent, chemotherapy can actually achieve cure, and we've seen it in some of the cancers that we manage. So chemotherapy can achieve cure after you've achieved remission. And the diagram here just shows some of the patients undergoing some of the treatment. So with chemotherapy, you come, you are admitted, you get this drug in a bottle. We inject it directly into your vein, or we put it in an infusion bag and run it over some time. Or you can have radiation therapy where you lie on this table and then the source of radiation treats whichever cancer that you have on your skin or in your abdomen or in your chest. And then for biological therapy, we use your own immune system or your own white cells to fight the cancer. And then for stem cell transplants, you have someone donating healthy cells to you. So the person donates these cells and then we inject it into your body to start the whole blood cell formation again. Other important therapies include nutritional and hydration supports, and then emotional and family supports, because studies have shown that most of the times, individuals who have adequate nutritional and hydrational support and also emotional and family support usually have more than, it's like therapeutic, more than 50% of your issue is solved. The rest is to treat the disease with the chemotherapy. So eating well, making sure you're eating morning, afternoon, evening, having enough fruits, eggs, everything is very important when it comes to the management of patients. And then more importantly, also emotional and family support. You can imagine if you get diagnosed of a blood cancer and you are the only one to carry this burden. You don't have any family, there is nothing, and you are just at the hospital and you are wondering how to manage yourself. This alone is not going to make you survive. And then follow up. Patients who start treatment, sometimes once they start their treatment, they start feeling better, maybe after one cycle or two cycles. And we always notice that once they disappear from the clinic and they don't come back again, they come back later, they report back with very, very bad disease, and they don't do too well. So listening to your doctor and making sure you do all that is said is very, very important. In the long term, as I said, we want to achieve remission, we want to achieve the cure. And then we shouldn't forget that during treatment, you can also have complications with the chemotherapy. So some patients may lose their hair, some may develop ulcers, and some may even die from the complications of treatment. So we typically will advise those, especially the young women and men, that they should be able to save some eggs or ovaries at fertility bank, so that if in case the treatment affects their fertility, they will have eggs and sperms for conception later when they plan on doing so. And you can also have, there will be death if you are basically not treated. So before we delve into the Black Cancer Foundation, I just want to present some statistics over the period of from January to November 2024 from the Cape Coast Teaching Hospital. So for patients that we saw at the OPD, at the adult OPD over a period of 11 months, we noticed that the highest frequency of blood cancer was seen in a disease called non-Hodgkin's lymphoma, and it was 28%. So that means that 23 out of the 83 blood cancers that we managed at the OPD. And OPD just basically means the outpatient department. So it's the clinic that we manage. And this finding is not too different from studies that were done in Nigeria, where we know Ugu noticed that for patients that were seen in a clinic in Nigeria, NHL was again the most commonest. And then in Ghana, about 8 years ago, NHL was again the most commonest. And this is also not too different from the world. Non-Hodgkin's lymphoma is the most commonest blood cancer. For those who came directly into the emergency or those who were managed on the ward, we saw 48 blood cancer patients. And out of these 48 blood cancer patients, 12 of them had AML. And AML is an acute myeloid leukemia. So the highest incidence of patients that we managed at the ward was acute myeloid leukemia. And this was followed by non-Hodgkin's lymphoma. With the mortality, out of the 48 blood cancer patients that we managed on the ward, 13 of them died, which represented 27.1% of the total patients that were managed. And this implies that for every 3 blood cancer patients that we admit to the ward, 1 of them is going to die. So for every 3 patients, 1 of them is going to die. And the highest recorded frequency was seen in AML, acute myeloid leukemia, where 5 out of the 13 patients died. And then this was followed by acute lymphoblastic leukemia. So all this are leukemia. So in total, 8 out of the 13 patients had the leukemia. And the remaining were other diseases like lymphoma. So what is the stressing here? The alarming and distressing point here is that the first thing is that if you are admitted for a blood cancer and you fall, I mean, you are part of one of the three, one out of the three cases that have been admitted will die. And then secondly, for those who had AML, almost half of them died and none of them is in remission. And seven are currently, I mean, seven of them are not in remission now, and we have none who is in remission. So 5 have died and 7 are still having symptoms and signs. And for ALL, all the 3 patients that we admitted, all of them died. So this should tell you that if unfortunately you have an acute lymphoblastic leukemia, you are likely to die. So the reasons for these high mortality that we've just discussed in CCTH were because of these reasons. As these were the reasons that I saw as I saw these patients from January to December. So there was lack of awareness and inadequate education in the general population. I noticed that most patients, they don't even understand what blood cells are. So whatever that happens to them, if they have some bleeding somewhere or they have other issues and they don't feel too well, they'll go to pharmacies, they will self-medicate, they'll use herbal preparation before they report. And by the time they come, the disease is far advanced. They were also not able to afford the investigations that were requested for them. So that means that we can't better classify their disease and we can't better manage them. And then they can do that. Some can do the test, but they are unable to purchase the medications that are needed to manage their disease. And we also notice that the average health workers in Ghana are not aware of the clinical presentation. So sometimes some of them tend to manage these patients with transfusions and blood tonic and all other hematinics for some time before they are subsequently referred. And this delay the diagnosis and early referral. On the part of the facility, we also noticed that there are inadequate supportive therapy because sometimes some of the blood cancers are good. I mean, when I say good, we've noticed that a lot of patients do well when they are managed. So they come in with anemia and we need blood, but because of the unavailability of blood, these patients end up dying because of the anemia, and it's quite unfortunate. And then there's some of the facilities are also poorly resourced to manage patients who have some form of immune dysfunction. So with patients who have blood cancer, they are immunocompromised. That means that their immune system is weak. So they tend to develop certain infections. And for these patients, you would want a clean environment where there are no infections, okay, or people will not come and transmit infections to them because sometimes you will have leukemia, but surrounding you, you have other patients with pneumonia, sepsis, and all that. And these people can just be coughing and they will just transmit these infections to you, and we lose a lot of people from infections. There's also absence of data that can guide our local management of blood cancer patients. And also, there's absence of a functional stem cell transplant facility for patients who should be able to undergo these processes. So for the birth of Blood Cancer Foundation Ghana, we've seen a number of blood cancer patients, but in 2024, we had a young man in his 30s from Cape Coast who was diagnosed of acute myeloid leukemia. He presented with all the symptoms and signs that I've told you, having bleeding from the nose and other places, feeling unwell, anemia, and all that. And he resorted to treating himself by using herbal medications. Once he realized he wasn't getting better, he decided to report to some smaller facilities, clinic facilities. And whilst he was there, he was transfused, he was given platelets, and that was over a period of 2 weeks. They also gave him blood tonic, and he wasn't getting better. So once they realized that he wasn't getting better and he had developed other things, he was subsequently referred to our facility. So when we saw him, we gave him supportive therapy, we performed a marrow, and then we made a diagnosis of a leukemia. And we requested other investigations. But unfortunately for him, he had used his money on other treatments and he couldn't afford any further. So we decided to break the news to them. We told we told him and the family about the disease, they really struggled to understand what leukemia is. I mean, they couldn't even understand what blood cells are for them to even understand what leukemia is. But to some extent, we were able to let them understand. And they decided to go ahead with therapy. We told them the limitation, because for him, I thought he needed a stem cell transplant because he's 30, he was young, he had a very good physiological function, but he couldn't get that. So we decided to do chemotherapy for him. Unfortunately, he couldn't also afford the chemotherapy. So we managed him palliatively on a drug called hydroxyurea till he passed after some months. And this is the story of many Ghanaian leukemia patients who don't really achieve remission. We try doing our best for them, but because of the blocks and the boundaries, we are unable to do 100% for them. So the questions that we've asked ourselves over the past years are, when are we really going to get a comprehensive workout for these patients? When are they going to start receiving more newer regimens? And when are they ever going to have hopes of achieving a cure by stem cell transplant? Because I remember, just this Friday, I've had a 35-year-old female, a teacher, who was diagnosed of an acute lymphoblastic leukemia, and she's quite educated and has read about her disease. So we're trying to tell her about the fact that she can get a cure and all that. She was a bit happy because she thought there was hope, until I decided to tell her that we don't have a functional stem cell transplant, so she may have to go out if if she can be able to afford it. But in the meanwhile, we can do chemotherapy for her, for which we've seen a number of people achieving a cure with it. But it can go any way. It can go bad or it can be good at the end. But I realized that when I said the stem cell transplant, she was happy until I told her that there were limitations. And you could see that it was a very big burden on her. Many years ago, blood cancers were rare. Not that we didn't know of it, but it was just because there was limited, not that they were not being diagnosed, but there was limited knowledge. And over a long period of time, we've had consultant hematologists like Professor Ankrabedu and Professor Bruce Tego, who are currently of pleasant memory. And then we've also had Professor Akwe, Professor Olayemi, Professor Ekem, Professor Dea Adomakon, Dr. Amabene Akusukuma, over the past years, having trained many hematologists in Ghana to improve the diagnosis and management of these patients. So the numbers are increasing, even though the number of hematologists are inadequate. And they are working hard to make diagnosis and treat the patients with the limited resources available. So we shared stories and realized that the stories that we find here are not too unique. It's not just unique for this particular patient. There are similar stories everywhere. And I can count the number of times I've written medical reports for patients to go and seek for funds, where for every patient, I have to sit down at the end, write a letter, sending it to various radio stations, TV stations, churches, everywhere, to try and seek for some form of funds for these patients. And these patients, once they come in bleeding from their nose, we try and stabilize them a bit. They will tell us they don't have money, so they want to go home and seek for funds. And they come back 2 weeks or 3 weeks later in a very bad state with just a little amount of money, which can't do anything for them. So it's like this has been the story over the past years, and we've seen over the past many years, it's like we are just at that same place where patients are not affording, patients are not getting the adequate diagnosis, even though we do our best. And we thought that someone had to speak for these patients, someone had to change the narrative, someone had to set up something that there can be a stable fund for these patients to be able to get a constant supply of financial aid, so that they can confidently know that once they have cancers, they are likely to survive to some extent, at least if you are not even going to prevent death. If you are going to prevent death within a short period of time, yes, that's better. Trying to improve the survival and shifting the patient's death from maybe 1 month to 12 months is good for the person, so that the person can have more time with the family and do a lot of things before he or she dies. And the real situation is not too different from the situation that I discussed from our hospital. It's the same thing. So I'm not going to go through these points again. The same issues are being seen everywhere. So with our vision, we want to make a difference. And the difference, as little as this difference may be, we still want to make the difference. And our vision is that no one should face blood cancer alone. We typically have patients coming into the clinic. Sometimes they are just alone. We break the news to them. And you can just realize that they are just alone in this. They don't have any good family support, because once the family hears this, it looks like financial burden and they have to deal with it on their own. And we also want to make sure that there will be a world, a Ghana, where blood cancer is no longer a silent killer. And again, the similar situation as you have a patient goes home and trying to seek for funds indoors, not going anywhere, constantly bleeding from the nose, the urine, and losing blood, having later on getting anemia, and then reporting finally to the emergency at a very bad state and coming to die. So this is what we mean by a silent killer. They are just indoors dying silently. So for the key components of our mission, we want to raise awareness and educate the general public. We want to support patients and empower them. We want to make them feel that cancer is not the end. I mean, you can get cured and have positive vibes, and also support these patients by ensuring that we have a transparent and a stable financial fund or aid for these patients who constantly may need support, and also improving access to treatment and care, advocating for better policies for these patients so that these things can be covered by insurance. I mean, their diagnosis and their treatment, and then also making sure that we have constant researching in all our facilities to provide data that can help better manage our patients. Our hopes and dreams are to establish a comprehensive cancer center in the future, specifically a hematology malignancy diagnostic center, which will serve as an institution for a complete diagnosis of blood cancer patients, and also to offer ideal treatment options, including a stem cell transplant for every blood cancer patient across the country at an affordable price. Because I can tell you that there are patients who have blood cancer. I mean, they've not even been diagnosed at certain corners of the country. They don't even get to be diagnosed. And even when they are diagnosed, the issue is how they can be transported from that place to a facility where they can be managed. So there are so many boundaries that prevent these patients from getting the adequate treatment. We hope to receive donations from everyone, because this can't be done on our own. We need a constant supply of money to be able to fund these projects and ensure patients are constantly being supported. And we need money from individuals and philanthropists, organizations across the world, governments of Ghana, governments from other countries, associations, and businesses. And recently, our co-founder, Sebastian Pevans, came all the way from Germany to assist us in this virtual launch, and also travel across the country to help with some little donations. And this is just a shot of one of the donations that we did at the Cape Coast Teaching Hospital, where he was able to donate a variety of medications to some patients who were unable to pay for some of their medications. That's just a preliminary effort prior to the launch of the virtual launch. So we hope that this will be a starting point for everyone. And this was actually also made possible by one doctor at Oberhausen, Rheinhausen in Germany, Dr. Alexander Fischer. He was able to make this funding, this donation possible, but Sebastian had to travel from Germany to come and represent him here. And he's the co-founder. So we already have partnerships with the Ghana Association of Hematology. We are all part of it as hematologists. It's an association that has been there, which supports patients, not just blood cancer patients, but everyone who has a blood-related condition. And then we also, in partnership with the Leukemia Lymphoma Project Foundation, and we also want partnerships from everywhere. It shouldn't just be healthcare related. We want partnerships from businesses, from farmers, from drivers associations, from lawyer associations, from banker associations, from everywhere across the country. You are all welcome to help support this good projects. And you can contact us by sending us an email, and you can also call us if you have any inquiries. We have our social media platforms, and you can send us a message through these areas or send us a WhatsApp here. Thank you, and we'll take any questions and submissions to improve this foundation. You can scan this to follow our official websites, and also you can follow us on our social media pages. So again, thank you very much, and I'll take any submissions if there are any. Hello?
Hello,
So,
thank you very much, Kisiedu, and congratulations. This is a wonderful project. Thank you very much.
Thank you, Prof. So if you have any questions, you have any submissions, I think it will be good that we have some discussions before we leave the platform. So you can scan these to follow the site if you are already not following us. Okay, so if there are no questions or submissions, I think we can bring this presentation to an end and the launching to an end. Thank you very much, everyone, for joining us today. I hope that whatever that we've learned here, we can send it across. It shouldn't just end here. We should send it across to other people who were unable to be here. We'll have excerpts of the lunch that we had today. We'll have them on our social media page so that everyone who couldn't be here will have a recording and everything. We'll post some around, and anyone who would want to re-listen to it, or anyone who would want to do something for this foundation should contact us, and we should be able to help out. So I want to thank everyone once again. Yeah.
Emmanuel, sorry to cut in just before you round up finally.
Yeah.
Your co-founder, I would be glad also to know why he was interested in a project like this. For you, it's clear.
Yes,
but
please.
I would be glad to know that as well, if possible. Thank you.
Yes, please. Yes. So with my co-founder, he's a friend of mine from Germany, and I started having a discussion with him concerning some of the issues that we face in Ghana. And he told me that I think he has participated in, not the main man, but he has participated in various organizations where he's been able to help. I mean, not him directly, but he has participated in organizations that he's seen that they've been able to help people who need financial aid and all that. So he thought it was a good project, and he wanted to help me since he's at the other parts of the world. So he's in Germany, and he can be able to work on his parts from that side of the world, and then I can also do my parts here on the side of the world, and we can come together to do something great for the foundation. So it was just a discussion that I had with him, and he thought that he shouldn't just sit there. he's motivated to help us get this foundation to somewhere that will be very beneficial to our blood cancer patients. So that was basically the story of him being.
Okay, thank you. Thank you very much.
You're welcome. Okay, so I think at this moment we will call it a day. And thank you all for joining us. If you have any other questions or inquiries or submissions, you can always send us a message or follow us on our pages and send us a message, and we'll be glad to reply. Thank you very much, and enjoy your day, and Merry Christmas in advance. Sebastian is here. I don't know if he wants to say something. He speaks more German than English, but I don't know if he would try to say something before we finally leave. If not, then it will be the close for the day.
Yes, please. So thank you.
Right.
You know, your passion is really good. And then this is also the reason, because we really want to help also from Europe, from Germany. And now it's a small project, and we hope that it becomes bigger and bigger. So let's see what we can do this year and next year, and to help some people, and to get your vision comes be true.
Okay, thank you very, very much, Sebastian. So as I said initially, we are working together, and we are working together to help blood cancer patients in Ghana. So see you all later, anywhere we meet. Thank you very much. Bye. And Merry Christmas in advance.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye-bye. Merry Christmas.